So we'll continue to talk about tendons around the foot and ankle. Michael, why don't you take this case?
Okay, so on the first image, axial through the calcaneus, we see this prominent bony protuberance. And it looks like there's probably the perineal brevis is probably anterior to it, and the perineal longus is posterior, so perineal tubercle.
And here's a sagittal.
And you can see on the sagittals that's definitely splitting the two longus and brevis, so it's consistent with the perineal tubercle.
There was a study a number of years ago that looked at about 50 of these and didn't feel that they were statistically correlated with tendon pathology, but I think that was way too small of a sampling. And again, the pathology is in the longus, because you can see how it can be tented overlying this tibial tubercle, and how you could get traumatic injury as the tendon flexes and extends around the tubercle, whereas the brevis extends anteriorly and really isn't involved with mechanical association with the perineal tubercle. Okay. Ashu, what do you think of this one?
This looks like a retromalleolar eminence, because I think I see two soft tissues anterior to it, but it'd be hard to tell on the CT. But I think I see the Peroneus brevis and the Peroneus longus tendons anterior to it.
Yeah. So yeah, actually, I can see what you say, that this is actually the longus right here.
Oh, okay. So that is a peroneal tubercle with splitting of the Peroneus longus?
It's not really splitting the Perineus longus. We can see distally the longus is very thickened here, and this was, and you can see a lot of abnormality of the perineal tubercle here in this. So this was a perineal tubercle. Jennifer, what do you think of this one on CT?
All right, so here again we can see this prominent kind of osteophyte cut along the calcaneus, and there's tendinosis of the Peroneus longus. And also it looks like there may be some degenerative changes between the distal fibula and the talus.
Here?
Yes.
Okay. So here we can see this is another perineal tubercle. I wouldn't call it an osteophyte. I'd call it a perineal tubercle. And there's the brevis looks normal anterior. The longus does not look normal posterior. There's a lot of tendinosis, and we can see abnormal signal intensity here within the longus. And here's the perineal tubercle. And then you'd want to look on the fluid sensitive images to see if there's edema within the perineal tubercle as well, as an indication that it could be a cause of symptoms.
So here it looks like we probably have another perineal tubercle, but that edge of the bone is very ill-defined. Like I don't really see a definite cortical lining. Maybe it's just very edematous. I don't know if this is just T1 weighted imaging. And yeah, so now we see quite a bit of edema. Again, there's some cortical. On the first image on the left, it looks like there's, on the non-fat side, it looks like there's some cortical irregularity, but then I feel like I can see the cortex on the PD fat side. So I think it's just an edematous perineal tubercle and with some tendinosis right there. I don't know if it's injured, like acutely injured. Or...
Well, this this patient did not have trauma, just gradually increasing lateral foot and ankle pain over several years. And here we can just see the extensive trabecular bone injury involved in the perineal tubercle, the extensive tendinosis involving the longus, the brevis looks normal. Again, a symptomatic perineal tubercle. So, you know, if you don't see any bone edema is pretty uncommon in these. If you see a normal looking tendons, then it's probably not going to be a cause of symptoms. A cause of symptoms are where you start seeing increased signal intensity and thickening of the Perineus longus tendon, and then the bone edema. Okay, Ashu.
All right, here is a definite perineal tubercle. It's splitting between the Peroneus brevis and the Peroneus longus. The skin marker is actually overlying the Peroneus brevis. The Peroneus longus doesn't look too abnormal, maybe a little bit increases signal, but you see the peroneal tubercle is actually mildly edematous there. So I think that's probably the cause some friction on that.
So this is
peroneal tubercle.
11008, and we can see, just like you're saying, the tendons don't look too bad, but there is bone edema there, because that's 11008. This is patient is now 3309.
All right, so here we can see that there's been erosion of that peroneal tubercle. It's more edematous. I don't really see the Peroneus longus tendon very well on the axial images. On the coronal images, you can kind of see the differentiation there, but I think this is probably and even more. I think there's probably even more signal there. So I think there's a lot of tendinosis Peroneus longus there, and I think there's edema and some erosion of the peroneal tubercle.
So what do you think's happened here?
Did they resect it? Did they take it out? Yeah. Okay.
This is postoperative, and the patient continued to have pain after surgery, and we can see that there's a lot of bony reactive changes there, even after surgery, and some tendinopathy within the longus tendon. Okay. And this again, in contradistinction to the retrotrochlear eminence, a normal finding, not a cause of symptoms, where we can see both tendons anterior. This is a common mistake to call this a perineal tubercle. Okay, and then if we go more distally, we're talking about the longus tendon, the Perineus longus tendon. If we go distally, this is from a paper, you can see distal tendinopathy here at and distal to where it goes around the cuboid. Again, where it goes around the cuboids is another location where it rubs against the bone, and tendons don't like rubbing against the bone. Generally, there's a cartilaginous interface there, but if you break down the cartilaginous interface and end up with bone against tendon, the tendon usually doesn't like that, and neither does the bone. And here we can see the longus coming in, and brevis looks normal, longus looks normal, proximal. When we get at the level of the cuboid, we can see a lot of tendinopathy within the longus tendon. And as we go around the cuboid and extend over toward the medial aspect of the foot, we can see a lot of increased signal intensity within the cuboid. So this is severe distal Perineus longus tendinopathy at the level of the cuboid. So that's the third location where you have to be concerned about tendinopathy. And here, this is proximal to the cuboid. There's the cuboid. If we're at the level of the cuboid, we're starting getting increased signal intensity, and it goes around the cuboid on the plantar aspect. We can see a lot of increased signal intensity. Again, tendinopathy at the level of the cuboid. And again, here we can see a lot of increased signal intensity within the longus tendon at the level of the cuboid, and a lot of tendinopathy. Okay. And then this is should be a black structure coming around to insert, as we talked about before. So that's distal Perineus longus tendinopathy. And there's just more of it. This is a distal tear. Okay, Jennifer, what do you think of this case?
Okay, so it looks like we have some sagittal, coronal, and axial images of the ankle. There is thickening of the Peroneus longus tendon with increased fluid in the tendon sheath, and it looks like it may be retracted. I would want to evaluate it distally to see if it's torn distally and retracted.
Yeah, it looks like this all the way down to the cuboid, and this is really a diffuse injury to the Perineus longus, which is another less common pathology. Usually it's at one of those three locations we talked about, but sometimes it can be much more diffuse. Okay. Michael, what do you think of this case?
Okay, so first image, it looks like there's probably a little ossicle, os peroneus within involving the peroneal longus. On the stir, there might be a little bit of edema within it, and maybe a little bit of tendinosis around it as well.
So this is called an os peroneus, or peroneal ossicle. And this is the classic location of the os peroneus, which in Keats is considered a congenital variant or a normal variant, which I don't think is the case.
Keats described as the book of misfractures.
Yeah, right. Keats. Okay. Ashu, what do you think of this case?
Looking at this sagittal image, don't really see much abnormality here. Oh, I see it. Peroneus longus partial tear. Okay, it's definitely thick in there, and there's decreased signal.
Yeah, it's hard to see on that one image, but this was on 4/14/2000. The person came back about 4 years later, and this is what it looked like.
So you can see that it's ossified, and now there's an ossicle there.
Right.
Right.
I've seen a number of these develop over time when we followed patients over time. So I think that I've already talked about it in all the other areas too. So it's this is gross repetition, but I think most of these ossicles within tendons and ligaments are acquired, and they're due to partial tears and the healing of those partial tears. But the body loves to heal with bone. It does not like healing with tendon and ligaments very well. Jennifer.
So here we can see an corticated ossific fragment in the Perineus longus, but it's not where we would expect it for an os peroneum. It's much more proximal, so I would still be concerned about a tear with retraction and retraction of the os peroneum.
Yeah, I think that's a good idea. You have to look distally and see. In this particular case, this is probably someone who had a partial tear up here by the lateral malleolus, which is one of the 3 locations where you commonly have injuries, and it probably healed with ossification here, the sort of thing that usually happens down by the cuboid, but that process probably happened more proximally in this particular case. But it's a good thought to look to make sure you don't have a full thickness tear distally and proximal retraction with ossicle.
Okay. So I see kind of a circumscribed area of increased signal adjacent to that, I guess, 5th metatarsal. Do you have any other?
Hey, John, are you joining us? Okay. Sorry. Okay. All right. I did. We'll keep looking for you. Yeah. Okay, so this was a little injury.
Mm-hmm.
There. Do you know what structure that might be over there?
No, I assume it's probably one of the intrinsic muscles. Yeah.
So this is actually this is a go-go dancer with pain in the left foot.
All right, 29-year-old female, pain in the left foot. Stepped on glass. All right. So there seems to be some abnormal increased signal right where the skin marker is, deep to it, along the fifth metatarsal, right there. Yeah, I think this might be a torn. It looks like it's torn, partially torn, right there. Yeah.
Okay, here are some longitudinal images. You see this particular tendon coming there and then stopping.
Yeah, it's discontinuous there, and it's torn.
So what's torn?
Is that the Peroneus longus? Or, no. Yeah, abductor digitorum. Sorry.
So occasional tear, but yeah, this one caused some difficulty in dancing. Hi, John. You are able to join us.
I made it. I don't know what's going on with this thing, but
Okay, yeah. Yeah, I've been grappling with computers as well lately. Jennifer, what do you think of this case?
Okay, so we have some images through the distal foot, and it looks like kind of along the lateral aspect of the fifth metatarsal, there's some lobulated fluid kind of near the abductor digiti minimi.
Yeah.
So this
This
is
is another tear. So it's basically 3 tears involving the adductor digiti minimi. Okay.
Okay. So the first image, there's a lot of irregularity and sclerosis along that superior aspect of the calcaneus. A lot of soft tissue, like thickening infiltration around it and scarring. And then the next images are kind of the similar appearance. I'm wondering, do we have any other reformats? Because it looks like there's probably, like, I don't know if it's involving the sinus tarsi or also the, like, lateral gutter right there, just because it's in proximity to the fibula.
We haven't really talked about this.
So, I mean, if there's a lot of soft tissue there, I'm wondering if there's, been
What kind of soft tissue is it?
like scarring.
Okay.
So you'd worry about like anterior lateral ankle impingement.
And the patient had lateral pain from lateral impingement. We'll talk more about impingement syndromes later. Then we can go to the medial tendons. It's a posterior tibialis, flexor digitorum longus, and flexor hallicus longus tendons. And again, you're familiar with the anatomy here, but just going over it. The posterior tibialis tendon, flexor digitorum, flexor hallicus. And as a rule of thumb, the posterior tibialis tendon cross-sectional area should be about the sum of the hallicus longus and the flexor digitorum. And we'll see that some of the early signs of pathology are enlargement of the tendons, even though the signal might be the same. So kind of eyeballing the cross-sectional areas are helpful. And then, and here we can see the more distal posterior tibialis tendon, and here's that superior spring ligament, and some of the more deeper structures we talked about before. On the sagittal images here we can see the flexor hallicus longus tendon coming down under the cestum tachinum talus, and then vessels out here. Now, as we talked about a minute ago, any tendons that have to go around and rub on bone, bones and tendons don't like each other. So in those locations, there are typically articular cartilage that develops on both the bone side and articular cartilage side, and the cartilage can slide with respect to each other just like it does in a typical joint space. So this is called the Synovio-Entheseal complex. And on the posterior tibialis tendon over on the medial malleolus, this should be intact. One of the ways in which the posterior tibialis tendon can develop tendinopathy is for overuse and destruction of this cartilage, which then no longer allows the tendon to properly move with respect to the bone in a frictionless manner, and you start getting then tendinopathy and bony changes, which can lead to degenerative disease. Now, distal.
it's sort of like forming a callus.
Yeah.
Kind of thing.
Yeah, I'll show some examples of
it.
Yep. Good, John. Now, the distal PTT inserts at a lot of different places. The prominent insertion that we typically see goes to the navicular bone. But as you can see, it kind of peels off and goes to the second, third, and fourth metatarsal bases. It can go all the way over to the cuboid and come down here to the calcaneus. So there are many distal insertions. And often we can see that, and sometimes you'll actually see that it may even miss the navicular and just insert more distally in the cuneiforms and metatarsal bases. Okay, so Let me see, who's next? Nobody knows who's next? Michael, why don't you take this one? Medial ankle pain.
Okay, so there's this low intensity kind of soft tissue appearing structure right there, I think involving the kind of in the region of the posterior tibialis tendon.
So this is the PTT.
So I'm wondering if it's actually like part of the tendon. So it just looks like it's really thickened right before it attaches to the navicular. So at least tendinosis of it. I don't see any fluid sensitive. I don't see any fluid signal.
So the distal part of the PTT, where it attaches close to the navicular, if you look at it histologically, it doesn't look just like tendon there. It typically has fibrocartilage, which develops a substantial amount of the distal posterior tibialis tendon, and this is actually normal. People often call it tendinosis, not a big mess, but this is the normal fibrocartilaginous distal aspect of the posterior tibialis tendon, where it becomes thickened there, and that it often will then insert in a broad band here on the navicular. But this also is the area where you develop the accessory navicular ossicles that we'll talk about in a minute in this fibrocartilaginous matrix that's normally in the distal part of the posterior tibialis tendon. Okay. Ashley, what do you think of this one?
So we're looking at the posterior tibialis here. There's a lot of edema or fluid, I would say, along the tendon sheath there, and there's some increased signal within the posterior tibialis tendon, and I think this is some tendinosis and tenosynovitis maybe.
Yeah, so this is a typical posterior tibialis tenosynovitis and tendinopathy which develops. And this is one of the more common pathologies which can develop typically from overuse. And also when you have ankle sprains, you can acutely strain the tendon and produce tenosynovitis as well in this particular location. And we'll see why this can be serious as we talk about more serious pathological consequences of posterior tibialis tendinopathy. So you can often get fluid in the tendon sheaths here. In fact, I would say it's rare not to have fluid in the Flexor Hallicus longus tendon sheaths. It's a little bit less common to have it in the Digitorum and the PTT, but people have looked about how much is too much. But basically, if you have a fluid that with a linear dimension is greater than 9 millimeters, this paper says that correlates with medial ankle pain and early stage 1 posterior tibialis tendinopathy. I don't remember these numbers. I typically eyeball it. Okay, Jennifer, what do you think of this case?
All right, so here there is diffuse thickening surrounding that posterior tibialis tendon. It looks like scar tissue. I don't see a lot of fluid, so this is probably chronic, at least moderate to severe tearing and tenosynovitis.
Yeah, so this is more chronic tenosynovitis, probably from chronic inflammatory change to the synovium around the PTT and the flexor digitorum. And over a long period of time, actually you lose the acute inflammatory appearance and it becomes more fibrous as fibrosis replaces the acute inflammatory disease. So this typically then leads to lack of the PTT performing its function. You no longer have the medial pull of the posterior tibialis tendon on the distal part of the ankle and the navicular. And we'll see over time the pathology that leads to in a little bit. And in the old days, people would do bone scanning. And
John,
go ahead, John.
I'm sorry. Can you go back? This is synovitis and maybe a little granulation tissue.
Yeah.
If you had scarring here, the tendon wouldn't move, would it?
Yeah, probably wouldn't move much. That's right.
So this ankle would be basically frozen. That's the only way I could look at that.
Okay.
So, do you know any history on this fellow?
I don't remember it. I knew it at the time, but I don't remember it now.
Yeah, but you don't see any space around the tendon. All you see is dark tissue, whatever that may be.
Right.
But if it's scar tissue, then nothing moves.
Right.
Well,
Good.
that would be a frozen ankle. But it says here tenosynovitis, which would allow motion.
Yeah, I don't remember.
I'm just asking.
I didn't examine the. I didn't really examine the patient. I think that it wouldn't allow much motion with the PTT, but it would allow motion other areas within the ankle. But I don't remember the details in this particular patient.
Okay, because this is a very prominent tendon on the foot.
Yeah.
So
exactly, and this is pathology of the posterior tibialis tendon is very common. This kind of marked thickening of the synovium around it is not so common, but when you see this, this is typically in the MR literature called chronic tenosynovitis.
yeah, it's
It's very progress on biopsy.
a lot of abuse of this area, I guess.
I think so.
I'm sorry to interrupt you.
Yeah, that's good. Thanks, John. And then in the old days, we would do bone scans, and you can see some uptake here of the navicular, medial aspect of the navicular at the posterior tibialis tendon insertion. We don't do that anymore. Okay, Michael.
Okay, so we see a well corticated bone fragment right there proximal to the navicular involving the posterior tibialis tendon. So it's like a type 2 ossicle.
It's a type 2 ossicle. It's been, the syndesmosis has been torn and it's avulsed proximally, right? And that's accessory navicular, and that's a separation of the syndesmosis between the two. Okay, Ashu.
All right, so I think this is a 21-year-old male with medial foot pain. We can see almost a bipartite type 2 in the os navicular. I don't know if it's fractured before, but one of the parts is quite edematous on the inferior, the plantar aspect. So I'd be worried about a painful os navicular syndrome here.
I don't think that this is an old fracture, do you?
Yeah, I mean, I think it might be, especially the fact that it looks like it's, the type 2 os navicular looks fractured, but it's well corticated. It could be an old fracture plus edema of that.
The navicular is nice and smooth here. So I
meant the
this is a
the
fracture
type 2
of
os
the os. This is probably a fracture of the os, right?
Right.
Which we can see here. And then, here are the axial images.
Yeah, and there's actually some posterior tibialis tendinosis as well.
Yep. Here. Okay, good. Jennifer.
Okay, so here again, it looks like we have another type 2 os navicular, and there's just a few marrow edema surrounding the os navicular. This could be seen with posterior tibialis tendon dysfunction, yes, and a painful navicular.
Yeah, so they call this osteonecrosis, which I don't think is the right word to use. It probably is osteitis and trauma, and this leads to posterior tibialis dysfunction. And if it's left unchecked and untreated, it will go on to the processes that I will show you. I promise I'll show you in a little bit. Okay. All right, Michael.
Okay, so it looks like we have another accessory ossicle of the naviculars. This looks like a type 2. And on the first image, it does look like it has some decreased signal within the marrow, so it's probably edematous, and there is edema across the synchondrosis as well. So this should be a pain generator. And that almost looks like it's actually a Volstov, well, which it is, PTT Avulsion.
What we used to on X-ray, chip fracture.
Yeah. Yeah. Okay. Ashley.
So there's quite a bit of increased signal of the posterior tibialis tendon. It looks very thickened and increased signal throughout there. And I don't know, but it looks like this is an acquired pes planus deformity. I know I can't see the talus, but it kind of looks like that.
Some degenerative disease.
And you said early degenerative disease there as well. So.
Yeah, so this is really a chronic tendinopathy of posterior tibialis tendon, which then leads to abnormal function of the posterior tibialis tendon, which over time means that you don't have adequate traction on the medial structures, and this then leads to acquired flat foot deformity, adult acquired flat foot deformity. Part of that is you get breakdown of the spring ligament complex, you get acquired pes planus, and then it goes on to a valgus deformity of the calcaneus and hindfoot and lateral impingement. We'll see all of those shortly, but that's chronic posterior tibialis tendinopathy. Good. Jennifer.
Okay, so on this image, we have some sagittal images of the ankle, and I don't see that normal longitudinal arch, so I'm concerned that this could be pes planus.
Okay.
Okay, so then we also see a retracted tendon up at the level of the distal tibia. Okay, so that's the retracted PTT.
Right. So this was a complete tear, which was chronic, and this patient has acquired adult acquired flat foot deformity due to posterior tibialis chronic tendinopathy or lack of function. Good. And then here's another one, another pes planus, abnormal posterior tibialis tendon. It's markedly enlarged. You got fluid around it, and this is chronic posterior tibialis tendinopathy with another acquired flat foot deformity patient. And then if it continues, what you can then get is, since you no longer have proper medial tug on the bones, the navicular, and remember a big component of the PTT goes to the calcaneus as well, if you remember that anatomic structure that we had. When it fails, the calcaneus then is unstable and it goes into valgus. You get acquired flat foot deformity, and you start getting lateral displacement of the calcaneus, which then abuts up to the distal fibula, and this is hindfoot valgus and bony lateral impingement. And this is kind of the end stage of adult acquired flat foot deformity. And that's all due to posterior tibialis tendinopathy. So it's very important to pick up the posterior tibialis tendinopathy early and try to intervene before this slowly progresses. But there are years of a lot of pain.
Tendinopathy and tear, John.
Yeah. And there is an alpha angle here, like there is in the hip and other places. Here you take the long axis of the tibia, the long axis of the calcaneus, and here you have to go to the posterior calcaneus in the coronal plane, not anteriorly. And then you have this angle here, and it should be less than 6 degrees. Bill valgus is if this is greater than 6 degrees. Okay. So adult acquired flat foot deformity, this is a nice article reviewing it in radiographics. It starts with posterior tibialis tendon disease or tendinopathy. You then get a strain on the the talonavicular joint. You get loss of the 3 primary arches. At first it starts out as a flexible malalignment, where you get a kind of a plano-valgus deformity, where you get flexion of the talus, early hindfoot valgus and eversion, flat foot. And if this goes on over time, then you end up getting a rigid malalignment that's much more difficult to treat. And the arches that they're really talking about are the arches where you go up along the dorsal aspect, really involving the second metatarsal bone, the coronal plane up around the cuneiform bones, and then the plantar arch, which we see down here. And you can measure those differently, but basically all three of them become abnormal and flatten out and when you get posterior tibialis tendinopathy over time. And then if you also look at other things, you get malalignment. You can see there is a lateral rotation of the foot of the bones of the midfoot and the metatarsals and tarsals, really primarily at the talo-navicular joint space, right in through here. You get lateral deviation. Again, this is because you do not have the medial tug from the posterior tibialis tendon working properly. And therefore, the forces when you put your foot down on the ground are trying to push all of these bones laterally, and the tibia above forces the talus medially, and you get rotation at the talo-navicular joint space. And this is another part of the malalignment. You get an adult acquired flat-foot deformity from lack of tension from the posterior tibialis tendon. And in this article, they kind of go through the gait and how this is important for the gait. And so what they point out is if you actually look at EMG studies, the posterior tibialis tendon is only active during the stance phase. That's when you have pressure on the foot and the metatarsals, which then would force them laterally. The posterior tibialis tendon keeps them midline. And when you lose that PTT is when you start developing the loss of the different arches. And when you push off also. And then the secondary ligament abnormalities you get from failure of the posterior tibia is the tear or stretching of the superior medial bundle of the spring ligament, where you get thinning or thickening, and it can be torn. You get abnormalities of the sinus tarsi, and then you get a lot of tendinopathy of the deltoid ligament because now it's being strained beyond what it's designed to do. Remember, the tendons and the muscles are the primary structures designed to make sure that the bones are in proper orientation. When they fail, the ligaments are the backup. But if the tendons and muscles aren't working and you only rely on the ligaments will become stretched out and abnormal. And that's what happens with posterior tibialis tendinopathy. And I think that's also the primary cause of back pain, because of people not maintaining the strength of their back muscles. They sit all day long, and the ligaments take up to try to keep the bones from becoming displaced, and that leads to chronic pain syndromes primarily associated with the ligaments. And then you get secondary to degenerative disease because of the tendons are not properly aligning the bones when you put pressure through the spine. And then you can also get the flat-foot deformity. So any questions about adult-acquired flat-foot deformity? It's very common, and it's an extremely common cause in adults of chronic foot and ankle pain. Okay. And this is just, we talked about the three components of the spring ligament. It's really important for maintaining two of the arches that we talked about earlier, the one in the kind of the coronal plane.
Are you saying it's common in everybody, or is it common in rheumatoid arthritis and such things?
I'm not familiar with it being primarily associated with rheumatoid arthritis. I think it's a fairly common cause of severe foot and ankle pain in adults, because the posterior tibialis tendinopathy is not picked up early enough and treated, and it progresses to the fixed deformity phase.
Yeah, well, the posterior tibial tendon is extremely important. In my experience, I have not seen too many people with that problem. They usually take care of it pretty early on. They don't let it go like some people do with their backs and knees and so on. But the posterior tibial tendon is quite painful, and most people don't let it go this far where they get a flat foot. That's kind of not that common a thing. Flat feet are common, but that's from birth.
Yeah. Good. Okay. And then we talked about the spring ligament complex before, and then the deltoid ligament, both of which can be damaged by this process. And have we talked about the plantar fascia yet? I don't think we've talked about it. We'll talk a lot more about the plantar fascia later, especially pain, and even a much more common cause of foot and ankle pain is injury to the plantar fascia. But it could also be involved in this process, because when you get loss of the normal arches above, what happens is that can affect the plantar fascia here. But
that is extremely common, John.
right, exactly.
I've seen hundreds of cases of that problem.
Yeah. And so typically we have the kind of little triangle here, the normal arch. The base of that is really the plantar fascia. If you start losing the bony arch up here, it starts stretching the plantar fascia down below. So these are all connected together and can produce multiple areas of pain when you start having failure of the normal structural processes in the foot and ankle. And we'll talk a lot about the plantar fascia later. And then one of the findings that you can see on physical examination is the too many toes sign. If you look from the back forward, you really should only see a little bit of the pinky here, the small one. But when you get the adult acquired flat foot deformity and hindfoot valgus, what happens is everything rotates out, and you can actually see much more of the distal foot. And so if you remember what we talked about, you get valgus deformity of the calcaneus, which angles the whole foot laterally with bony impingement here at the distal fibula. And then if you also remember, you'll get a medial angulation of the talus and a lateral angulation of the navicular and the cuneiforms, which throws the toes out laterally. So that's what causes this too many toes sign.
There's a little bit of that on the right side also, just not as far.
Yeah, good. And so what they described are 4 stages. Stage 1 is where you get swelling and tenderness along the PTT, but no deformity, and they say this should be treated conservatively. Then you get a flexible deformity with early heel valgus, and they think this can be treated by orthotics, and if that doesn't work, by surgery. Then stage 3 is inflexible deformity with heel valgus and hindfoot impingement, which is pretty far along, and this has to be treated surgically. And then stage 4 involves the tibio-talar joint, and again, that requires surgery. So you really want to pick it up in the early stages here, where you can protect the PTT and allow it to heal. There are a number of measurements that have been described in plain X-rays to look at this. One is the Meary's angle. The other one is the calcaneal pitch angle. Cuneiform to fifth metatarsal height, talus tilt angle, talonavicular uncoverage angle, and the incongruency angle. I'm just going to go through these, but I'm not going to spend enough time for you guys to really memorize them. I really don't use them, but if you're reading plain films and you happen to be in a practice where you work a lot with foot and ankle surgeons, these may be things that you'll have to think about. So A is really the one angle here where you can see the long axis of the talus and kind of the axis that goes through the navicular. So this is along the first metatarsal and the talus. And if it's greater than 10 degrees, that's abnormal, meaning pes planus. The calcaneal pitch angle is B back here. and this should be abnormal as less than 19 degrees. Again, what happens if you start developing pes planus, the calcaneus drops down here, and this angle becomes less. And then there's the cuneiform to fifth metatarsal height. Here we can see the fifth metatarsal there. And there are the cuneiforms. And this abnormal is less than 6 millimeters. What this means is that that coronal arch is, as well as that plantar arch are breaking down, and you're developing the flatfoot deformity. Other things to look for is a talus tilt angle, where you draw a line along the tibial plafond and one along the superior aspect of the talar dome, and it's abnormal if this becomes greater than 5 degrees. And the talonavicular uncoverage angle, this is where you're trying to look to see whether you're getting that abnormal angulation of the navicular with respect to the distal talus, and abnormal is greater than 26 in this one. And then the incongruent angle we have there is abnormal is greater than 70. And then, so what this study showed is that if you have an abnormal Meary's or calcaneal pitch angle, it correlates with posterior tibialis tendon tears and other support structures. So,
if you have a acquired flat-foot deformity, what's the chance you have a normal posterior tibialis tendon? Is it pretty low?
0.
Okay.
Okay, I have no idea who went last.
I think it's me.
Okay, go for it.
So I see the posterior tibialis tendon, and I see the flexor hallucis tendon. I don't really see the flexor digitorum tendon.
Okay. There distally. There.
I can see distally.
Okay, there are distally. If you come proximally, we can see them there.
Yeah.
Keep coming proximally.
Yeah. Oh, there is it. It's torn there.
Okay. So I'm sorry. Let me go back here. Okay. So there we go. So we're going. This is the flexor hallicus longus over here. These are the flexor digitorums. We keep going there. The flexor digitorum tendons. Here we go. Flexor hallicus digitorum, and then when we get up here, we're seeing the hallicus, but we're missing a tendon there. The digitorum isn't here. And
okay.
We come here. Here is the location where the flexor hallicus longus and the digitorum cross one another, and we only see one tendon there. There's a flexor hallicus, and there should be a digitorum in that location. So this was a complete rupture of the flexor digitorum. So good, you picked it up right away. One of the most difficult things to see sometimes is the absence of a normal structure. So it's good to make sure you see all three. Okay, Jennifer. We're talking about flexor tendons now.
Gosh, there's a lot of fluid beneath that first metatarsal, and I think this is in the region of the flexor hallucis longus.
Right.
So I'm concerned about a tear.
And if we go more proximally, there's the brevis. That's where the longus should be, but there's an empty sheath there. And if we finally come proximally enough, we start picking it up as very abnormal.
Okay, so it's retracted here.
Yeah, so this was a complete rupture of the flexor hallicus longus. And these typically occur right around the first metatarsal phalangeal joint and then retract back. And that's what this was. And typical in ballerinas and sprinters and people like that. Okay.
What do you do if you see it there, Jennifer?
So usually if I see a tear, I describe how far proximally it's retracted and what it's adjacent to. That way, if the surgeon needs to go in and repair it, they know where to look.
Yeah, the repair is not an easy one. So sometimes you have to use, and the foot hamstring tendons, allograft tendons are very helpful. Unless you want to use autografts, and you go for other kind of tendons, which are not always helpful. But for some reason, hamstring tendons have been chosen for the foot.
Thanks, John.
So there's a soft tissue marker right over the dorsal navicular, and those in the region of the extensor tendons. But judging by these two components, look okay, I think. There's some signal beneath or plantar to the navicular, yeah, right there, and it looks kind of abnormal in that second image. So there's like complete tear of, I'm trying to think which flexor tendon, and then you can see on the second area that looks like it's proximally retracted. Is this the flexor Hallicus longus?
But if you had all the images, you could follow it down and see. I believe that's a Hallicus, and I believe this is a Digitorum. And there we can see it. And this was a full thickness tear with retraction. No, this was the flexor Hallicus longus. Again, if you look on the axial images, it's easy to see which one it is. But this was a complete tear, in this case of the flexor Hallicus. So this was a flexor Digitorum. So we were a little bit more proximal than I thought we were. Okay, Ashu.
Okay, so the flexor digitorum longus and the flexor hallucis longus are pointed out here. They look intact. There is a lot of fluid. I think when they okay, so this is an intersection syndrome because as soon as they cross over at the master knot of Henry, you get that focal edema.
Right. Yeah, good. And a little bit of deformity of the tendon here too, where they're rubbing against one another. Excellent.
Friction.
What, John?
Friction.
Friction, exactly. Exactly. Jennifer.
Well, here we're at the level of the ankle. We have some coronal images, and I don't see normal appearing tendons. I'm not sure if there's multiple tears. There's a lot of fluid and edema surrounding these tendons.
Well, wait a second. I agree with you that you don't see a tendon. What do you see?
I'm not sure if this is calcific tendinopathy, or a foreign body, or Synovio-Entheseal.
So these are calcific bodies, multiple calcific bodies in the flexor Hallicus longus tendon sheath, and like other areas where you have synovium, you can get synoviochondromatosis.
Oh, these are osteochondromatosis.
Yeah, so this is osteochondromatosis, right? Okay. We're getting let's stop here, and we'll start this section next week. Okay. Thanks, everyone.
Well, everybody have a great weekend, and I'll work on my computer.